Yeah, our distinguished guests, ladies and gentlemen, welcome. First of all, we really thank you for honoring our invitation and and joining us today. As GDC, we are extremely humbled. My name is Omegere John Patrick. I coordinate GDC activities in Africa, and together with all our colleagues here, we are extremely happy to welcome you. As we had indicated, the discussions today would be a workshop around digital health, and we are also very honored to have representation from South Sudan, led by Mr. Chol, the Director General Health Services. We have Uganda, we have Ethiopia, led by Dr. Meseret, and we have Rwanda, led by Mr. Sibamona Hassan, Zambia, etc. Joined by other representatives of different countries here at the Dubai Expo. Most of them are Commissioner Generals of the respective countries. To kickstart our session today, it's my honor to invite the member of our Board of Governors, Dr. Chari, to kindly deliver the initial welcome remarks. Thank you, sir.
Thank you, Patrick, for those kind words. Very good morning to all of you, ladies and gentlemen. It is always a pleasure to be with people who believe in the dictum of cooperative framework. And I'm all the more thrilled when I come across people from South Sudan, Uganda, Ethiopia, Rwanda, Zimbabwe, because I work for the United Nations and I was in South Sudan, I was in all these places. It was really, when you meet people from these places where I have worked, it always feels as if I am back in the larger family. So that gives me a great amount of happiness and strength to be with all of you. This is the second day of our session. We at the RIS are working on a number of verticals. RIS, this booklet Global Development Center gives you enough material about RIS. In fact, I would take this opportunity to invite all of you to India, New Delhi, and visit our office. RIS is essentially it's an organization formed in the 60s by the then Prime Minister, and it basically works. It's called Research and Information System for Developing Countries. But in those days, developing countries were a block. But today we don't use the word developing countries anymore, we say emerging economies. So we are all emerging economies, from America down to every small little country is an emerging economy. So we are all part of emerging world, or rather we can say we are all part of an emerging world order. And in the recent times, the biggest challenge that we all faced was the challenge for this world order. A world order which more or less sustained all of us since the end of the Second World War, say around 1940-45, is being challenged. We also witnessed that war can be a very great intervention in the economic development and sustainable growth. But besides war, even more than the war, without even firing a single bullet, one small insignificant virus which cannot be even seen with naked eye stop the entire world. So we are all meeting in the background of a pandemic. which practically immobilized countries, wreaked havoc with economies, be it the economy of the US, China, Japan, India, or even smaller economies. Whichever economy was there, it was all ruined, stopped. So the developmental process came to a halt. Sometime in 2014-15, India thought in this direction, and our Prime Minister Narendra Modi in 2015, he launched what he called the Digital India. So we began to start thinking that we will have to bring the whole world into a cooperative framework. It could be cooperation between two countries, it could be cooperation between two regions, it could be cooperation between two areas like South-South cooperation. But what is important is we will have to have a cooperative framework. And as they say, every problem has a challenge and an opportunity. Pandemic was a challenge, but pandemic also became an opportunity. So it was during the pandemic that India put out under the National Health Authority, under the Ministry of Health, we started what we call the Co-Win. In India's ancient language Sanskrit, the word co means who. It's literally who wins. Even if one person loses, we all lose. And collectively, if we are able to work together, we all win. So it was a victory against a pandemic that became an experiment, that became an experience for the whole world. India was probably the first country not only to manufacture antivirus inoculation, but India was the first country to export it, give it free of cost to as many countries as possible. Of course, it had certain effects on India's own system, but we did not allow that to stop from approaching other countries. So much so that the first package was sent to none other than the United States itself, the country which produces the maximum amount of vaccinations. But it was that country which required vaccination from us. But it was a cooperative framework. So we thought that it would be very interesting, and under the aegis of RIS, along with the Global Development Center, we also have another very important area called Asia-Africa Growth Corridor. So we now bring in all these factors, Asia-Africa Growth Corridor and Global Development Center will jointly work. Since RIS is part of the External Affairs Ministry of India, we are an autonomous body under the Ministry of External Affairs. We have the advantage of having secretaries of health, secretaries of science and technology, finance ministry, and all other important ministries are ex officio members of our organization. So by virtue of that, we are able to coordinate with all the ministries, and also we have what we call our own IPSA forum, BRICS forum, and all these forums are also working together. So if you put all these forums together, there is a huge amount of opportunity for India and Africa to work together. We have common problems, we have common challenges, and we have common opportunities. Countries like, since I was in South Sudan, I can say that countries like South Sudan has the capability and capacity to produce food for almost the whole world. For the next 200 years, the world need not produce anything. One country, South Sudan, is enough to produce food grains for the whole world. That is the kind of strength that a country like South Sudan has. And for all these years, we have never been able to tap the potential of these countries, the potential of Africa. And these potentials cannot be tapped by one country alone. There cannot be an hegemonic approach towards cooperative framework. It has to be a cooperative framework, and it has to be a win-win situation for all. So that is why we emphasize on co-win, and we all want to share our experiences and how to proceed from here. Pandemics, they say, are there forever. Every 100 years a pandemic comes, and God forbid, let us not have a pandemic in the next 100 years, but that's not the question. We have to go on. If that has to go on, if people have to be protected against all these things, we will have to have a cooperative framework under the South-South cooperation and so many other frameworks. So how best we can evolve all these frameworks, how best we can think in terms of putting all these factors together, how to share experiences, how to share problems, and how we overcame our problems. Probably your experience in overcoming a particular problem would open the doors for solution for India. The way India has come out of certain problems will probably show the way forward for South Sudan or Ethiopia or Zimbabwe or some other country for that matter. So we will have to share our experiences, we will have to all live together, we will have to fight together, we will have to face the challenges together, and we will all have to win together. So that is the whole idea of co-win, and there are experts who have put together this whole idea and who have implemented this. So we in this session we will have a discussion on all those things. We can have question and answer sessions, we can share our experiences, and ultimately from out of all these experiences, whatever comes up, we will carry forward it in a practical form in the next coming meetings. You are all experts in your own field. I am not an expert on any medical related issue. So I don't think I should keep you all away from the next session for a long time. Thank you very much.
Thank you so much, sir, for your very elaborate comments. Like he has rightly mentioned, we really sit on the premise of sharing experiences among countries. And from this time onwards, we would be dedicating the time just to that. We would love to hear the Indian experience, and we would also love to hear your experiences, so that there is a common way for mutual development. So at this point, I would now take the honor of inviting India to lead the presentation. After the presentation and probably some question and answers, we would request each country to make a slight 5 or so minutes initial remarks on what exactly is within your country, and how you think the collaborations could be in moving forward. So thank you. I request Mr. Aviral Gupta from the National Health Authority, Minister of Health, Government of India, to please start the presentation. Thank you.
Thank you for the introduction. A very good morning to all the delegates here from all the respectable African nations. I am Aviral Gupta. I am an officer on special duty in the National Health Authority, and today I will be talking to you about CoWIN, which is our vaccination platform that has enabled the vaccination of over 1 billion people in India. I would like to start with a video on CoWIN first.
While the development and manufacturing of COVID-19 vaccine is one of the most amazing feats in the history of India, vaccinating 1.37 billion Indians is also not a trivial task. Here's the story of India's journey towards universal COVID vaccination with CoWIN platform. From the very beginning, we were walking on a tightrope to build a platform that embraced the geographical, cultural and linguistic diversity of India.
कुछ ही मिनट बाद भारत में दुनिया का सबसे बड़ा टीकाकरण अभियान शुरू होने जा रहा है। मैं सभी देशवासियों को इसके लिए बहुत बहुत बधाई देता हूं।
Under the dynamic leadership of our Prime Minister, India started the development of a scalable, inclusive and open platform called CoWIN. It is the tech backbone of India's vaccination drive, designed to serve as a single source of truth and help with strategizing, implementing, monitoring, and evaluating India's vaccination drive. Platform is designed to cater to the requirements of all stakeholders. For citizens, the platform provides multilingual, transparent, and easy to use web and mobile interface. 3 modes of registration: online, offline, and assisted. Guidance on interval between vaccine doses. Convenience in vaccination slot booking. Instant digital certificate. For vaccination centers, it enables vaccine stock management, efficient vaccine utilization, publishing vaccination schedules, verification of citizens through multiple modes, real-time dashboard. For government, the platform helped in ensuring its maximum of minimum government and maximum governance. It provides dashboards and data analysis regarding vaccination, mechanisms to prevent rent-seeking and black marketing, data-driven public health policy. In a nutshell, this is an agile platform that can be customized and scaled up for health interventions across the globe. The algorithms are designed to quickly respond and adapt. The platform has undergone constant evolution with changes in the vaccination policy. With each rollout stage, it became more robust, user-friendly, and fully loaded with features such as slot booking based on preferred vaccination brand availability, platform adapted for differently abled, registrations through 24/7 support through 1075 toll-free number, optimized capacity to handle load of billions of visits.
हमने जो टेक्नोलॉजी प्लेटफॉर्म बनाया है कोविन, उसकी भी पूरी दुनिया में चर्चा हो रही है। अनेक देशों ने भारत के इस प्लेटफॉर्म को इस्तेमाल करने में रुचि भी दिखाई है।
We are excited to join hands with the world to win over COVID-19 together with CoWin.
With that, I would like to start the presentation. First, I would like to take you through how the vaccination system in India worked. And before the development of CoWin, we had a system called the EVIN, the Electronic Vaccine Intelligence Network, that was being used for the physical supply of vaccines from the manufacturing sites till the cold chain units in each district of the country. But however, when we saw that we had to deliver over 1 billion vaccine doses in a very short time, there was a need for a digital system to come in to ensure that we did not have any kind of rent-seeking behaviors or any kind of inequities that are created, and we are able to take everyone forward together. And as you will see in the rest of my presentation, there were multiple other problems that we foresaw, for which we thought that we needed a digital platform to enable the vaccination drive in India. So this is exactly where CoWin came in, which is the COVID Vaccine Intelligence Network, a real-time recording of vaccination events. From the storage points, the cold chain storage points, once the vaccines were shared with the COVID-19 vaccination centers, that's where CoWin came into the picture, recorded the stock of vaccines that were supplied from these cold chain points. This allowed us to have a traceability of each and every vial of the vaccine, right from the storage point till the time it was administered. This ensured that there was no pilferage of the vaccine or there was no misappropriation of the vaccine, because we understood that, looking at the pandemic, how essential it was that the vaccine reached out to everyone equitably. Right from the publishing of the session plans by the vaccination centers to beneficiary registration, the vaccination platform allowed for individuals to make their own registration online, as well as register at the vaccination centers once they visited there offline. In due time, as you got your vaccination, there was an instant certificate that was generated, which was digitally verifiable. In fact, the first dose of vaccine that was administered in India, even for that, we had a digitally verifiable COVID-19 certificate that was issued. That is now being used very openly for travel, for opening of workplaces as well as public places in the country. Giving an overview of what COVID is and what are the guiding principles. So as I had mentioned previously, we were cognizant of the fact that as we launched this vaccination drive, we needed to ensure an equitable and inclusive access to vaccination for all, while also ensuring that all the stakeholders in the country, be it the government, be it the healthcare workers, the general public, the vaccination staff, everyone had a single source of truth, so that we were able to remove any asymmetry of information and prevent any malpractices from coming in. Naturally, we have all seen through the pandemic how the public health policy has evolved considerably with each passing week and month. Therefore, we had to ensure that the system was extremely evolvable and highly scalable, because while the vaccination production was scaled up overnight, we had to ensure that initially we might have had fewer people getting the vaccinations, but as the supply of vaccination came in, we would have had to reach a scale of 1 billion plus in less than a year's time. Above everything, once these vaccines were administered, it was also important to record the adverse effects following immunization, to be able to guide the public health policy on which vaccine would be effective. Therefore, the vaccination platform also allowed us to record that feedback for analysis and also drive a data-driven approach to public health policy. Just to highlight some figures, the robustness and scalability of COVID allowed us to reach over 200 million registrations in just 4 months, 400 million in 6 months, and we were able to cross 1 billion registrations in a mere 12 months, which has been the fastest scale up of any digital platform across the world. This beats the likes of the top big tech firms like Google, Amazon, or Facebook by not just months but by years in reaching that scale. Today we have over 1.04 billion citizens that are registered on the platform. Over 1.78 billion vaccines have been administered through the platform. What is interesting to note is that for each of these vaccines administered, there has been a digitally verifiable vaccine certificate that has also been issued. We have been able to record the AEFI, which is the adverse effects following immunization, for each of these vaccines administered. And this vaccination drive has been run through over 430,000 vaccination centers, each of which was using this platform. Now I will go ahead and talk about how this platform works and what allowed for these over 430,000 vaccination centers to use this platform at the same time. Talking about the architecture of COVID, we have ensured that the system is highly modular. When I say modular, I mean that we have broken the system down into functions, and each of these functions works asynchronously of the other function. So these 4 major functions are registration, which allowed for the registration and scheduling of vaccination slots. Second was for the facilities, the COVID-19 vaccination centers, which allowed them to publish how many vaccines they had, which brand of vaccines did they have, whether the vaccination was free or not, whether it was an online scheduled slot, or whether they could simply walk into the vaccination center. The third was the vaccination module, which allowed for the identification of the citizen as well as recording of the vaccination event at the vaccination center by the vaccinators. The fourth and the most important, which we have, fourth and the most important module that we have seen the significance of in the recent times. In fact, when we were entering into the Dubai Expo grounds, we noticed how everyone was asking for vaccine certificates. All of us, when we would have traveled into Dubai, there was a need to verify, whether a vaccine certificate is authentic or not. What is the veracity of the certificate? And that's one of the most important modules of COVID, which is the certification module. Here we have used an indigenously developed software called DIVOC that allows us to issue these digitally verifiable certificates in real time. As soon as your vaccination is done, the vaccinator is able to generate a certificate for you, and you will get a link on your mobile phone immediately that would allow you to access this vaccination certificate. Talking about this open architecture, this modular architecture, the most beautiful thing about this technology platform has been that it is interoperable. What I mean by interoperable is today you are able to talk to anyone over a mobile subscriber, irrespective of which subscriber you have. So if you are right now in Dubai and we have say 3 subscribers here, A, B, and C. It's not necessary for all of you to be on A to talk to each other. You can be on any of these subscribers and still be able to communicate with each other. The similar principle was applied here in terms of making this platform interoperable. Whether you were using, so we had various applications in our country like Arogya Setu or Paytm or the likes of Tata 1mg or Umang. You could have had any of these applications and yet been able to register yourself for vaccination. And we were able to achieve that because of the open APIs that we had published right from the time we made this platform live. These open APIs were able to allow other private as well as government organizations to integrate their systems with ours, ensuring that there is one single source of truth, that any individual who is registered centrally into the system. Any slot that they have booked is centrally recorded. The vaccination that they have been administered is centrally recorded, as well as the vaccination certificate which has been issued, that is issued centrally by our Ministry of Health for all the individuals. Talking about more on this aspect, therefore you see that for those 4 different modules that I talked about, we had different APIs for each one of them. So we had registration and scheduling APIs that provided us more fronts to have a larger outreach to our public, ensuring that whoever was comfortable with in whichever language or whichever UI UX platform was able to register for the vaccination. At the same time, while we had a lot of public run vaccination centers, we also had a lot of private players that had come in to drive the vaccination, as well as a lot of state governments had their own efforts driving vaccination. Therefore, we were able to allow them to integrate their existing systems with the vaccinator APIs. Therefore, they don't have to go outside of their native systems and yet be able to deliver all that information centrally. Most importantly, the certification APIs. Today, what we are being able to deliver is an access to download your COVID-19 vaccination certificate from any travel portal or any public facing portal, so that there is no dearth of access to your vaccination certificates. So today what we are seeing is that various travel portals like Ease My Trip or Go IBIBO or Make My Trip, they are able to let you access your vaccination certificates when you have booked an airline ticket or a railway ticket. At the same time, various insurance providers like Bajaj Finserv or the likes of Amazon Pay, they have been able to integrate with the vaccination, the certificate APIs to be able to retrieve the certificate to sell various products. What we have also enabled is a Know Your Vaccination Status API, which allows employers or public places to simply input your mobile number and your name to see whether you're vaccinated or not. This allows us to implement a policy of minimalism in terms of data sharing. All you share is your name and mobile number and your vaccination status, and none of your personal details. Talking about the advantages for citizens, some of the core functionalities that we have been able to deliver through COVID is the blended registration. So as I mentioned before, that vaccination centers can publish their schedules both for online registrations as well as offline walk-ins. So therefore, in rural areas where some of our citizens may not have been as technologically savvy or have had access to internet, they were also included into this system. As well as the more tech-savvy younger generations who don't know how to get away from their smartphones, they were able to access and book vaccination slots both for themselves as well as for their elders at their convenience. What we also offered was an assisted mode. We had made call centers live, wherein an individual could call the toll-free number, provide their details, and get the vaccination slot booked for themselves. We had also provided, the option to choose from multiple photo IDs. Therefore, we are not restricting anyone and allowing everyone to be a part of this platform. One of the very important things that we have seen over time is that the policy of the interval between two doses has varied over time. And we were that communication around that interval between two doses, 2 or 3 doses, whichever depending on the brand of the vaccine, it was important to be able to disseminate that information to the citizens. So CoWIN also allowed us to provide that information to the citizens, wherein they were able to see how many days were left for a vaccination, for the second dose of vaccination, and even through the system, we were able to send them SMS notifications, which allowed them to be which basically reminded them of when they are due to get their next dose of vaccination. The convenience in slot booking, while it is a digital system, it is also important to ensure portability. Say today I'm in New Delhi, but tomorrow I am traveling to Mumbai when I have to get my second dose of vaccination. Typically what we would have seen in previous days was that you would have had to go to the same place to get your second dose of vaccination. But because we had created a centralized system here where information could be accessed anywhere across the country, we were able to allow that portability in terms of getting your second dose of vaccination anywhere you were comfortable or wanted to get it done. And naturally, the instant digital certificate, which is issued centrally. In terms of making it a lot more inclusive, I would also want to add that, we provided offline features wherein, we had some of our healthcare workers going into remote regions wherein they were able to record all of the data offline. And as they reached an area where there was better internet connectivity, the data would get uploaded into the system in the background. And this allowed us to also tap those regions where there was no internet connectivity. We also tried to simplify the access to this platform by providing this platform in close to 15 native languages, so that no one felt left out because of the language barriers. At the same time, we ensured that the process of registration onto this platform is extremely simple. All you needed was your name, age, and gender. You input your mobile number, you get an OTP, and you're registered. There is no form of eligibility that's required to come onto this platform, and no complications so that anyone gets left out. As I mentioned before, we also ensured a minimal data inputs policy so that no one felt that they had to provide any kind of sensitive data, or felt that there is any kind of inhibition in terms of coming onto this platform to get your vaccination done. In this platform has been extremely important for the vaccinators as well, because what we have seen in the past and even today, that we mostly have closed loop networks or systems wherein one system is not talking to the other system, and what that how that affects an individual or a citizen is that there is no portability of their data, because of the fact that all the vaccinators were integrated into CoWIN or were initially using CoWIN and later on were able to integrate the systems with CoWIN. The data of the citizens, the vaccination event of the citizens was recorded onto this platform and was available to them as soon as they got on the vaccination certificate. So you may have gotten your first dose of vaccine from one private center, and you had the freedom to get your second dose of vaccine from a public center or from another private center. So that interoperability here allowed us to create a completely open network which benefited the citizens in the end. Just to talk about some of the features, there was the real-time dashboards that we have provided. So there have been real-time dashboards not only for the public but also for the vaccinators. So in case a particular vaccinator had multiple outlets, they were able to see how the vaccine utilization was happening at each of their outlets. It was important that when the vaccination started, each vial had about 10 doses, that we were effectively using these vials and not having any wastage. This allowed, these real-time dashboards allowed for not only head vaccinators but also district immunization officers as well as state and central authorities to evaluate in which regions were we facing a lot of wastage, and accordingly deploy solutions or give them advice in terms of how to utilize these doses or these vials of vaccines more efficiently and judiciously to be able to reach out to larger audiences and prevent any pilferage or wastages. For the government, this platform has been a boon in terms of having a single source of truth. I would re-emphasize the single source of truth because this was the first time in the history of a vaccination drive where you had a real-time visibility in terms of how many vaccinations had been delivered down to a district. Such was the case that in each district of the country, the vaccinating authorities as well as the health authorities were able to track how many vaccines had been delivered through the day. None of the officials were able to, paint a fabricated image or say, benefit their known tools by saying, oh, we did not get vaccinations today, or we did not we have administered all the vaccines today, we are out of vaccines. They have had to give an accountability of each vial of the vaccine, of each dose of the vaccine. And that was the biggest factor in providing a single source of truth to all the stakeholders involved in this vaccination drive. There was a tracking of AEFI for vaccines for the government, which is the adverse effects following immunization, which allowed for a data-driven public health policy. As I mentioned, we were able to granularly, geographically evaluate what was the penetration of vaccination in each part of the country. At the same time, we were able to issue digital vaccine certificates. That has been a big boon for us in terms of enabling international travel for our citizens. I have had conversations with over 115 to 120 countries that have recognized our system and have shown the willingness to build mutual verification because of the soundness of the system, because they were able to ensure that there is no way that this system can be frauded, or there's no way that this certificate which has been issued by this system can be defrauded. This is a view of one of the public dashboards that we have under CoWIN, which gives us a view of how many vaccines have been administered in a day, broken by age as well as by dose. Further, this also gives a breakup by region, by districts, allowing for vaccination authorities to pick up the pace wherever they feel that the vaccination coverage has not taken place effectively. Also, this was able to this was also able to help us in driving a more concentrated effort wherever there were COVID-19 outbreaks. That if a particular region is having an outbreak, we need to ensure that there is a faster and a more prompt efforts being taken to vaccinate the populations there. Talking about the certificate specifically, our digitally verifiable COVID-19 vaccination certificate had machine readable schemas that were centrally issued. This certificate could be used both digitally as well as physically. You were given a physical printout every time you got your vaccination done, but because you were also getting an SMS notification for the vaccination done, you could also access this certificate digitally. Now coming on to it's we have seen a great success with COVID in terms of what it has enabled us to achieve. And this is a great asset that has been created for us with over a billion people already on this platform. Now the question comes to us, how can we leverage this platform to do more? How can we increase the penetration of digital health in our country? And we have thought of doing that by first of all, opening this platform up for universal immunization program, so that when a child is born, instead of getting a physical card or a physical paper where each vaccine is recorded, and while this card may get misplaced or sometimes it may not be recognized by a certain authority, if we are able to replicate the same fundamentals and concepts that we have implemented in COVID into this universal immunization program, we will be able to enable a much more efficient and effective immunization of our newborns. At the same time, because this platform allows for modules on searching of various facilities, searching of various services that are available. Initially it was vaccination, but now we could also use those same modules for the blood donation for a blood donation platform, wherein individuals could find out where are the closest blood banks to them. If they want to donate blood, if they want to, if they're seeking a certain blood group because of an emergency. And the portability factor again comes into the picture. You may have donated blood at a certain point in time and your family may be in need of blood. So you would be able to take those credits of having donated blood earlier for your family, because there is a platform that is both interoperable as well as open to all the systems. This system could also be replicated for organ donation. And one very important thing that I'm going to talk about in terms of the future of COVID is how we are looking to plug it into our Ayushman Bharat digital mission. This Ayushman Bharat digital mission is our effort to build digital highways to connect all the stakeholders in the healthcare ecosystem. What exactly is Ayushman Bharat digital mission? When we're talking about citizens, this Ayushman Bharat digital mission, or the ABDM, is going to allow them to check the availability of various medical resources as well as discover verified healthcare professionals and healthcare facilities. They will be able to book these health services and order healthcare products, and they would be able to avail these things digitally or physically. For the healthcare providers, this will provide them with an accessibility and view of the patient's health history, because right now we were talking about digitally verifiable vaccination certificates, but as we increasingly drive more and more things digitally, we would be able to create the electronic medical records, or as we are calling them, the personal health records for all of the individuals. And once they get linked to a health ID, or what we're calling it as the ABHA number, Because that ABHA number is unique to each patient, all their health records across any healthcare system will start getting linked to this ID, and every time you're visiting a doctor, you will be able to share the longitudinal view of your medical history with those healthcare providers. And naturally, for the policymakers and program managers, this would be able to get them a view of public health at a national level, and at the same time drive action at a local level through the healthcare workers that are present on the ground. So if I gave you a view of how this system would work, how the Ayushman Bharat Digital Mission would work, so say a patient is seeking teleconsultation or wants to visit a hospital. In today's scenario, you could either approach a healthcare provider through an app, one, where your health records would be stored in that particular system, or you could go for a second platform or a third platform. But in all of these cases, what we would see is that these systems are closed, they don't talk to each other, all your health records are siloed. Each of these platforms in turn also have to onboard doctors separately. So therefore it might happen that a doctor may say that I'm already onboarded with platform 1, why should I come on to platform 2? And platform 2 might have a larger pool of audience or citizens that are connected with it. Then there is also an opacity to these systems, wherein what rules are they driving to run the system is not known to all the citizens or the healthcare providers. This is where the Ayushman Bharat Digital Mission comes in, where the fundamental building blocks, where I talked about the Ayushman Bharat health account number, that would allow all the citizens to get a unique number, which will help them to collate all of their medical records across the digital health ecosystem. There would be verified registries for healthcare professionals, for health facilities, so that there is more trust in the ecosystem, that any healthcare professional that you're reaching out to or any health facility that you're reaching out to is verified. Also for the digital health tech system, for them to innovate using these registries would be a lot more effective, as they will not have to spend as much on building or acquiring these doctors onto their platforms. And the most critical part is the ABHA app, or the personal health records app, which would allow a citizen to get all their records, medical records, in one place. So therefore they don't have to go around carrying big and bulky folders. And also, at times you would end up losing out to them. And as we grow into a more and more digital world, when you have to have digital consultation, teleconsultations, this would also allow them to share their medical health records with a doctor digitally, providing them an entire a longitudinal view of their medical history. Today we have a very strong and public-private partnership with over 600 private players and public players that have integrated with this Ayushman Bharat Digital Mission. The way I talked about COVID being interoperable, that is the fundamental that we are driving here through ABDM. You would have, some of you must have heard about UPI yesterday, the Unified Payments Interface. This is a similar effort from the government of India in the domain of health, where we are trying to replicate the success that we have seen through UPI in digital payments, now in health. Now coming on to sharing these digital public goods with the world. The way we have designed these public goods, we have made them open source, but we have made them open source for governments. So any government that wants to adopt this platform, or adopt a part of this platform. See, because a lot of governments are already halfway through their vaccination drive, but they may need a certificate module because of increasingly, increased world travel requiring these verifiable credentials. So you may need to integrate that certificate module into your current existing vaccination platform. So that's the way we have designed our COVID Global Outreach program, wherein we are able to offer you the entire platform or a part of it, completely free of cost. We have also created an entire network of system integrators who will be able to help you in terms of implementation of the platform. We have been fortunate enough to also have various donor agencies that have tied up with us to make the process of implementation of this platform, in other countries more, with less friction and faster. So the process, if today any of you would want to take a part of CoWIN and to bolster your existing vaccination platform, it would be extremely simple. You would simply need to reach out to either the National Health Authority or the Indian mission in your country, wherein they would then share an MOU with you. After the signing of that MOU, we would be happy to share the source code of this platform. We would also open up the various system integration agencies that we have trained for this. In case you feel that there is a system integration agency that your government is more comfortable with, we have also created the entire learning stack, the entire digital resources for that system integration agency to also come up the curve, learn about the platform, and then implement it within your country. I think with that, I would now be coming to an end to my presentation. What I would also like to add is the way we are viewing digital health. CoWIN has allowed us to, or given us the confidence that implementation of digital health at scale is possible, and CoWIN has very successfully demonstrated that. And we now want to leverage CoWIN's success to boost our efforts through the Ayushman Bharat Digital Mission, the ABDM, to revolutionize digital health, which has become even more important in the midst of this pandemic. And that is the same proposition that the government of India wants to offer to the world, wherein we want you to, we are happy to share CoWIN as a digital public good, and think of CoWIN as a gateway to a larger digital health ecosystem, where you could also share your digital health learnings with us, and we could share our digital health learnings with you, and also maybe take Ayushman Bharat Digital Mission to your countries to further have a globally interoperable digital health ecosystem for the benefit of all of our citizens. Thank you. I'm open to questions now. Does anyone have any questions?
Yeah, thank you, sir. Thank you for the good presentation. So I would like to ask, so actually even before COVID, you were using a digital platform for vaccination. So how are you integrating with this new system, CoWIN, and the other existing one? That is one question. And also, I would like to hear the investment you made, because actually I was surprised to vaccinate 25 million people per day. So it is something really, I don't know how to explain it.
No,
So we have been vaccinating the whole year. Now we have vaccinated only 80 million. So of course there is also other issues related to vaccines availability. But I would like to hear investment you made in terms of devices, trainings, to make this happen, because actually it's not easy to understand to vaccinate 25 million a day. So can you please elaborate more on that side also of investment? What was the cost really of introducing this CoWIN in all places? I have seen more than 400 South-end health facilities vaccinating. So it is a huge system. Can you please elaborate more? Thank you.
Absolutely. Thank you for your question. Firstly, we had a digital platform before COVID, but as I had mentioned, that was focused more on the supply of vaccines. So that had come up in 2015. That was purely focused on the supply of the vaccines from the manufacturing sites till the cold chain points. There was no citizen facing vaccination platform in the country that was allowing citizens to interact with various vaccination facilities. Most of those things were more physical, wherein you would reach out to any nearby vaccination center or a healthcare facility where you go, say, either get your polio drops or get your the various vaccinations that are required for you as a child. So there was no there was no digital system available. So in some sense, that was a boon for us because we did not have any legacy issues that we had to worry about when we were creating Coven. So we had a blank canvas in front of us, which is why we were able to design a system which was so open and scalable. In terms of costs, I'm happy you asked that question because we have built this system very frugally. You wouldn't believe, but the charge to build this platform was given to the CEO of National Health Authority on the 8th of January. On 16th of January, the platform was live. So there was just a team of 5 to 6 engineers that was sitting overnight, day and night working on this. And naturally, over the next 4 to 5 months, they added a lot more functionalities to this. So we have built this system extremely frugally. And we have not, spent a lot of money in terms of building this platform. In terms of the adoption of the platform, the good thing has been that in India we have in the last 5 to 6 years we have seen a great penetration of internet and data services within the country. Therefore, there is an already existing market of smartphones and tablets, and therefore the way we designed the system, we kept it extremely agile and open. This allowed us to simply deliver applications in the form of a normal app to any vaccination center. So the vaccinators could simply download this app on their phone. They would have the defined user logins. So this is why we didn't have to invest additionally on enabling these vaccination centers, which is why we didn't end up spending a lot on building that that ecosystem around it. But the good thing has been that the fact that the digital aspect of it or the internet connectivity aspect of it has to be more at the vaccination center. This gave the freedom to the citizens to just walk into the vaccination centers. You wouldn't believe that while this is a digital platform, over 80% of all the vaccination doses that have been administered by physical walk-ins. So it's only about 15 to 20% of the population that has actually gone on the website and digitally registered themselves for a vaccination dose. Mostly others had simply walked into the vaccination centers, and it was at the vaccination centers that their vaccine event was recorded, or they were registered onto the platform, which was extremely seamless as well. Please.
Thank you very much. It was a nice presentation, sir. Thank you for that. I do have one question with regard to infrastructures, for example, where areas that have no internet connections, how COWIN will work on that?
Absolutely.
Thank you.
Thanks for that question. As I mentioned previously in my presentation as well, the vaccinator module of COWIN, it also allows for an offline version, when you are in remote areas where there is no internet connectivity. you can put on the data of the citizen onto your system or on a handheld device, and later on, when say after 2 to 3 days you have covered a particular area and you're back into a connectivity region, you would then be able to upload all of that data into this central system. So therefore, anyone from that remote region, if they are then traveling to a region wherein they have internet connectivity, they would then be able to access their medical records. Or say tomorrow another vaccinator is going to that region, or someone from that region has gone to another remote region, they would still be able to get the information of these individuals and be able to effectively administer the follow-up doses of vaccines. Yes, I hope that answers your question.
Thank you for the nice presentation, and I can certainly say it's quite impressive.
Thank you.
And big congratulations to the government and the people of India, and also my friend here. I still remember the days when India was going through the biggest wave, and to us it was looking like COVID response could all be about supply system, and I still remember seeing, the transportation of the oxygen cylinders, the oxygen to the health facilities, by air, by road, by all means, to the biggest population that was to be reached. What I'm actually specifically asking about are three things, and my colleague has already asked about the investment made. I would appreciate if you can further elaborate on what were the limitations. We know India launched the biggest vaccination campaign in the world, and you have made a milestone or an achievement that is really admirable. So it would really be good and inspiring for countries, and in a forum like this, to have more information of what were the challenges or the limitations and how did you overcome them. One of the colleagues also asked about areas where there is no network. Some of us are coming from countries where it's not just an issue of the network. You might also have part of the population that do not have access to the phone. They don't have phone numbers even, So I do not imagine clearly how such situation could have been handled. As you look also at at what has happened, is a success that has been, I can see it is actually multi-agent response or multi-stakeholder, and certainly is not a success that can be claimed by a single agency.
Absolutely.
So we would really need to also see what were the contributions from other agencies that have contributed or ended up with this great achievement, knowing that having the vaccination platform falling into an integrated system. We could see some of us, we do have the dashboards, which is just one component of all this.
Absolutely.
Which doesn't tell much. You still do a lot of things manually. You still struggle to reach out, and you are still not reaching very, very, very much. So it would also be good for us to know this integrated system. It might have been existing already, but we some of us would really need to see how best we can learn from your experiences, know your challenges. It is at our time not a wise idea to still fall into the mistakes that others have already gone through.
Absolutely.
So it's better to learn from the mistakes of others. Thank you.
Thank you, sir, for your questions, and I think you've asked some very thought-provoking questions. In terms of, I'll start with what are the biggest challenges that we have faced first, and then I will talk more about how the structure of implementation took place, and how maybe a country where you have connectivity issues, you could still go ahead and use a platform like this, which is a digital platform. Uh, the biggest challenge that we faced was actually getting people to the vaccination center. Was not as much about enabling vaccinations. There was naturally either a vaccine hesitancy or a vaccine complacency, if I may say so, wherein initially, once the first wave had subsided, and by God's grace, we did not, go through a very bad first wave. There was a certain degree of complacency that you can get away with COVID-19, and you may not need a vaccination, so to say, or you will get a vaccination when needed, or when it comes up. And I feel that's something that most countries across the world have observed. And it was only the havoc that the second wave wreaked, which really drove people out of their homes to get the vaccination. So naturally, that was one of the biggest challenges that we faced, and even and that's somewhere where COVID actually helped us, because what we also later on saw was that a lot of individuals who had gotten the first dose of their vaccination didn't get the second dose of their vaccination, and there was a huge fallout that we saw, wherein in a lot of particular regions, people had gotten the first dose of vaccination, and they were well past 4 to 6 weeks, beyond the 4 to 6 weeks that was prescribed to get the second dose of vaccination. So COVID allowed us to have that visibility by region in terms of who are these individuals, and because we had that visibility, the district immunization for officers as well as the states, they were able to reach out to these individuals electronically. We were able to send out IVR calls to them, the automated calls. We were able to send out SMSs to them, and that actually helped us to increase that fully vaccinated proportion, as this thing opposed to only a single individual dose being administered. In terms of individuals not having a mobile number, you talked about, right? That's we were cognizant of that in a lot of rural regions it might so happen that an individual might just have one mobile number in a whole family, right? And though everyone in the family may not have a mobile number, what we allowed for was that up to 4 to 6 members can be registered on a single mobile number. So say if I'm logging in from my mobile number, I could add 4 users to it. I could add myself, my sister, and my parents, right? So this allowed for us to have a larger outreach, and account for those individuals who do not have a mobile number. The way the system is designed, it is highly configurable. So if this needs to be changed, if the login shouldn't be a mobile number and should be something else, right? If it just has to be a national identity number that your respective country has, that is more that has a larger outreach, that login could be turned into that ID number instead of the mobile number as well. So that is the degree of configurability that the system also offers. As I had mentioned previously as well, for regions that are remote and don't have internet connectivity, we have the offline module wherein COVID data can be uploaded later on once you're in the connectivity zone. And in terms of, I think, the structure and rollout overall, the way we had designed the vaccinator module, because we have a more federated architecture in terms of health. Health is a state subject and not a center subject. We had allowed for control of each state and the districts within each state, to admin users within each state who are able to control who gets access to this platform. So say, as you had mentioned, that there were various stakeholders that came together. So it was through each district immunization officer that anyone could gain control of this platform to become a vaccinator. And for the citizens, so to say, there was no, there was no eligibility. The system for the citizens, it was bereft of any eligibility so that anyone could come in and get their dose of vaccination.
Thank you very much for the exciting presentation, and I would like to also congratulate the people of India and its government.
Thank you.
Good morning, colleagues from the distinguished states. I have a few questions. You were trying to address most of it, and my question will be, what is the sustainability mechanism that you have as a strategy for the COVID? That is the number one question. The second is, what mechanism do you have to protect the data? Because the individual data is already stored. So what mechanism do you have to protect the data? And the other thing is, what is the actual investment to vaccinate a single person? Because this definitely gives us learning experience to know that whether this is cost effective or not, whether this is affordable or not. So I am really keen to hear the investments that you have already put for that. And the other thing is, how many percent of the population in India they have the cell phone? I'm really thrilled when you mentioned 1% can log in for 4 or 5% for their relatives. That's the best mechanism to send the SMS. But still, I'm really keen to know what population of the Indian population is having the cell phone, because that might really make things easier to reach to the community. And perhaps I'm bombarding you with many questions. How did you come across, and what, or perhaps the mechanisms that you use to address equity? Because one of the global agenda is addressing equity, vaccine equity within one country, within one district, within even lower down to near to the community. Because I know India is a very vast, large country.
Absolutely.
With a different geography. So how did you really come across with addressing equity? So the last point will be, what are the challenges in terms of the health system?
Okay.
I don't think this will be like a smooth way that we come up with, like vaccinating 1 billion of individuals, but there are many challenges and experience you have. So that might be really good to know what are the challenges that you face in terms of the system, like including how you really reached out everyone. How is the mechanism to deliver logistic and vaccine, and also the information system, to how you really manage the disinformation, misinformation, how these billions of people have been really vaccinated. I'm really keen to learn more from this. Thank you very much once again.
Absolutely. Thank you for your questions. Just on your first question, I would want you to elaborate a little more on when you mentioned that, talking about the sustainability of this system. So what aspect are you particularly referring to when you're asking about sustainability of the platform?
Very good, because you have mentioned this can be used for blood donation, organ transplantation, maybe additional other health issues can be addressed. So, for example, if you are going to have another, like another COVID, how you can really use this one as a benchmark to transfer to another system that you are going to launch.
All right, perfect. Thank you for your questions. So I will start with your first question. As I had mentioned in the end that, we are fortunately now seeing that, the world is opening up, and, all of us are able to now here, meet in person. I remember, I think it was almost about a year back in May, when we were having a similar discussion on, all of our nations sharing learnings. In fact, it was, I think, organized by GDC as well. And all of us were logging in through a Zoom or a WebEx. And today we are all able to be here in person. So with that in mind, naturally, if we could have it our way, maybe COVID-19 vaccinations are only here for another 18 to 24 months. And this large digital public good that we have created, what more can we do with it, right? When you talk about the sustainability, how more can we effectively utilize this platform, because we have over 1 billion people already on this platform. So as I had mentioned, we also have an Ayushman Bharat digital mission that is being brought about, wherein we are looking to connect all the stakeholders in the digital health ecosystem. So we feel that COVID will play a very important role there, because it already has an open and interoperable system. So right now we are working on integrating specific aspects of COVID with the Ayushman Bharat Digital Mission, the ABDM, so that we can increase the use cases that we can achieve through COVID. Because if we look at COVID in its crude form, it basically has one module that allows you to search various facilities or various services, while here the only service was of COVID-19 vaccination. Because the system is modular, you could add other services as well. As I had mentioned, that it could be universal immunization, it could be blood donation, it could be organ donation. Tomorrow it could even be a general teleconsultation, right? Any kind of medical service can be also listed on the platform. So then it could also be used by the facility itself to publish their schedule. How many slots do they have in a day in their outpatient department, right? Or how many surgeries can they accommodate within a day? So while vaccination or the COVID-19 vaccination was just one use case, because the system is so open and configurable, it can be used for any other medical service or product as well. Because nothing is hard coded at the back end. Everything is extremely variable driven. So you could change that variable or add another variable of another vaccination, of another healthcare service. So that's where it makes COVID a very sustainable system and worthy of a national investment. Because as I mentioned at the end of my presentation, the way we are seeing COVID today, it is a bridge to digital health, to achieving digital health, to expanding the number of services you could offer to your citizens in collaboration with the private stakeholders in the domain of health. Coming to your second question about data privacy and storage, one thing that we have ensured is that because it's an interoperable system and everyone's connecting with that system through APIs, all the data comes and gets stored within the central database of COVID. And anyone who requires anything from COVID, right? Firstly, no entity or no organization can download citizen level data with this thing. So even if today various state governments have to reach out to individuals who have only had their first dose of vaccination, we have provided them with the service to send out that communication through the platform. We are not providing them with the access to the data. We have ensured that everywhere any data that is coming out of COVID, it is anonymized and it is aggregated. So you can, as I'd shown in the dashboard, do we have internet access here? Yes. On this laptop? I would in fact love to show you the dashboard. So on the dashboard, you would be able to see how you are able to dissect the data based on date, right, or the time or the age of citizens, or by what dose have they received, or by the region. But you will not get citizen specific data. Therefore, that is able to allow us to ensure the privacy as well as the data security. So as you can see, this is the website and we have our dashboard here. This is a real-time dashboard. So what you see out here is the vaccinations happening in real time. Today, about 200,000 individuals have come onto the platform. Over 1.3 million doses have been administered today. If you go further down, you have overall statistics. You have statistics broken down by time, by doses, by age. Uh, you have it broken down by gender, by vaccine type. Uh, Most importantly, this has been extremely critical for various district and state level authorities to get a view how many individuals have been vaccinated in the specific region. So this anonymization and aggregation allows us to ensure that everyone is getting the important information, yet the privacy of the data of an individual is maintained. And what is even more important is that in terms of input of data, we have again ensured a minimal policy of data input. We are not asking for any extravagant details. We're simply asking for your name, age, and gender. Nothing beyond that, because nothing else is required to deliver vaccination to an individual. Then talking about you asked about the investment or the cost of vaccination per individual. So far, we have not done any studies that would give us a view of how much did it cost us to deliver the vaccination of each individual. But what I can assure you is that we have not spent more than a couple of $1 million to build this entire platform, because we kept the system extremely simple, extremely open. What we focused more was on building out the APIs and publishing them online, so that if anyone wants to have a fancier UI UX, right, wants to build out a system that is more intuitive for a citizen to access, or for a vaccinated to access, that allowed us to basically create an ecosystem of innovation. So any private or public player could come and build the system on top of it. And this is where one of the challenges also came in. So initially what we were seeing was, because health is a federated topic in our in India, it's a state topic, it's not a central topic in terms of our constitution. Various states had come up to us and said that they would want to drive vaccination as per their own accords. They would want to use their own system. And because the government of India was sourcing vaccination centrally, it gave us some soft power to drive the decision making in terms of what platform should be used. So because this platform is open and interoperable, we were able to then urge the various state governments to integrate with our system, so that they are able to maintain their own digital systems. At the same time, we are maintaining a central repository, a single source of truth for the entire country. Have I missed any of the questions in the end? That's good. Thank you.
Thank you, Mr. Gupta, again for a very wonderful presentation. I had a few questions in terms of, is the COWIN a completely digital system without any paper backup? I know there's an offline version, but do you have any paper mimicking the system that can be used in a very, very remote area? And then what is the average time of processing a client, a walk-in client, from registration all the way up to when they get a jab? You are vaccinating thousands in a day. How are you ensuring you don't have queues? We have very few, but that registration process all the way up to vaccination is producing queues in some of our centers. So what is the average time that would take to vaccinate a client from registration all the way up to when getting a jab? And then how do you ensure that the data is of quality, because you're continuously doing it on a daily basis. Errors of misspellings, a wrong ID, and then you want to produce a certificate and it's not correct. How do you get back with continuous vaccinations to correct that? Thank you.
Thank you for your questions. Very realistic questions in terms of implementation of a vaccination system. Starting with how much time does an individual take to get vaccinated at a vaccination center? I'll give my personal experience. I walked into the center. I was with the vaccinator. Besides the line waiting time, once I've reached the front of the line, it only took about anywhere between 2 to 4 minutes to get my vaccination and be at the waiting area, because we in our country we ask individuals to wait for 30 to 45 minutes so that in case there are any adverse effects following immunization, they can record that on the platform. But it did not take more than 2 to 4 minutes at max. Because the way we have designed the system, we are taking very minimal inputs of data. So any individual coming in with their ID, we would simply note down name, age and gender. So the data entry remains minimal. That in turn allows us to ensure that not a lot of mistakes are there in data entry, because at the point of data entry is where you have maximum number of issues. The other way we were able to ensure that it's a fast rolling process, and we don't have a very long queues or a lot of waiting time at vaccination centers. We were able to distribute the load by providing a digital view. So what would vaccination centers do is they would say that if in a day we have a supply of about 100 doses of vaccine, so they would distribute it across different times of the day, and they would publish that say we have about 40 slots that are open for walk-in, or 60 slots that are available digitally. You have to digitally book, or it could be the other way around, where you have 20 slots that could be digitally booked and 80 slots are for walk-in. So these were some of the ways in which we were able to distribute the load of vaccinations at each vaccination center, and at the same time ensure that there is not a lot of time that is being taken in terms of registration of an individual, and there is not a lot of data entry that is taking place, which is unnecessary and not of consequence, especially with respect to delivering a vaccine. Coming to your first question about whether there is a paper version of COVID. Unfortunately, we don't have a paper version of COVID, and that was by design. We did not want to have a paper version of COVID because what that would have again done is that would have slowed down the process. Like leads into the second question you had asked. If you have a lot of paperwork happening, that increases the workload of the vaccinators, that slows them down. And the simple question to be asked was, what do you need the paperwork for? Because in our country, there was no eligibility criteria to get a vaccine. The only paperwork that was there was in the case of initially healthcare workers, because we had started a vaccination drive with healthcare workers. So they just needed to have a certificate ensuring that they are working with a certain organization or a healthcare facility, and that document could be uploaded onto COVID just for verification. But besides that, we have not kept any paper equivalent of COVID for two reasons. One, to ensure the speed of vaccination, and second, to ensure the data privacy. As you add a paper version to anything, the cost of handling also goes up, increases the inefficiencies. So that's why we have been conscious of that fact, and by design we have not created a paper version of it. In whichever region there is no connectivity or internet connectivity is poor, for that, as I've talked about before, we have that offline module wherein a vaccinator can reach out to multiple individuals, record their details and vaccinate them. and in due time, once they're in a digital, in an area of connectivity, that data starts getting uploaded in the background. Sorry, have I missed any question?
Okay, thank you very much for the presentation. I have one clarification with regards to the offline mode. Want to find out how you are handling administration of subsequent doses, or with regards to the offline mode, how you are capturing data, and also how you get to provide the service to those who might not have received the first dose maybe from a particular site, but they get to receive the second dose from a different site in offline mode. Thank you.
Absolutely. So I think there's one implied piece of information here, that any system that is offline would be offline for a certain period of time, would not be permanently offline, meaning that if one of the vaccinators has gone to an offline region or a remote region where they don't have internet connectivity, they would be there for 2 to 3 days, and once they come back, that data would be uploaded back to the system. So what would happen is, the next time that they're visiting that region, they would have a list of the same individuals that had been vaccinated there before. So therefore, they would be able to make that call whether an individual has become eligible for the second dose or not. So it is a very a phygital system, so to say, a combination of physical plus digital, wherein you have that physical touch points through these vaccinators, but they are sort of the right word to use here is they're shuffling between regions of connectivity and very poor connectivity. So therefore, they are able to upload the data that they have recorded, and then they are able to bring back data on their systems so that they are better equipped to make a decision on who is eligible for a vaccination. And the way they operate in terms of data entry, it is the same as a vaccinator module would this thing function, wherein in a normal vaccination center, when you go there, you will provide your name or you will provide your registration number, through which your registration number or even your ID number, through which they will be able to retrieve you. I think the simplest way was you could just provide your mobile number and the vaccinator would be able to retrieve information about you. The same functionality had been provided in the even in the remote version. Naturally, there being a limited data set in that because you have a target audience. However, anyone from this target audience, if they then go into a digital area of connectivity, they would be able to get the second dose as well, because the vaccinator from who had made note of all of that data on their system were eventually able to upload it into their system, into the CoWIN system, CoWIN central system.
Okay, thank you for very nice presentation. I'm just asking question. I need to know about the that points you present concerning the this AEFI, this after events following immunization, and it is recorded 0.005, and just need a clarification. Things that those who are vaccinated are the one calling, or they are the health workers following after that. Thank you.
Thank you for that. So there were two aspects to this. One was, as I mentioned previously, once you get your vaccination done, you are expected to wait at the vaccination center in a waiting facility with social distancing, so that for 30 to 45 minutes subsequent to your vaccination, if any adverse effects come up, the vaccination center is able to record that at that time. We have also tried to build uh, a, a facility wherein someone can report later on, but it has been noticed that invariably that is not very effective, because anyone sort of facing any symptoms, there is a natural, nausea or fever that a lot of people have experienced after getting the vaccine, because of the virus. But that has not been this thing that has not been sort of considered in the under the definition of adverse effects. So mostly these adverse effects are recorded immediately subsequent to the vaccination at the vaccination center, because that ends up being the most effective. A reporting subsequent to that, once an individual has gone back to their place, has not been this thing observed a lot, or has not proven to be a successful mechanism to record AEFI.
Thank you so much. I think it is a very good presentation, and I must commend you and the government of India for this innovation. Just a follow-on clarification, probably on the issue of offline. We so many cases we've seen systems offline working in offline mode, and there is this seamless synchronization at the start. But now, given that there was a follow-on dose, the second dose that was supposed to be administered, and we know that there are instances where someone stays in a remote place and they are not going to move. First and second doses, they are going to have them there. So what happens if there is need for verification that so and so got the first dose here, and they need to be verified to get a second dose? We understand synchronization happened after the first dose, but now the second dose, is there a local instance that will be pulled from the server to verify on a local machine or
Absolutely.
mobile device? I just wanted to understand.
Absolutely. So another way to verify, whether someone's eligible for their second dose, is through their vaccination certificate. The good thing about the digital verification of a vaccination certificate is that the QR that is generated, it is not leading to a website link, right? Usually you have your QRs which are taking you, when you scan them, they take you to a web link, and where you can view a document or something. The way the QR has been designed, it can only be scanned using the COVID verification app, and that can be done in an offline mode as well. So today what happens is at border controls, when we have had discussions with various countries, we have told them that the way this system is designed, you can scan and verify a vaccination certificate even without internet, because when you will scan the QR code, we will read, so this is a private key with which each of these QR codes have been encrypted or locked. The verifier will have the public key. With the public key, you can read this QR code, does not require internet, and that would simply simply give you the information of the individual in terms of when did they get their vaccination, and because you would have 2 to 3 vaccines, or even 5 to 6 vaccines, you can even that way ascertain how much time is left for the second dose of vaccine. Completely offline, yet completely verified and authenticated. Besides that, on the vaccinator module of this vaccinator who is going to this region, they will also be able to pull data, because they would have some locally stored the data on the individual. So they would be able to also retrieve information on whether that individual is due to be vaccinated or not.
Thank you very much for your nice presentation. I'm very impressed by seeing what you have been done so far to come up with this very interesting result. Maybe I have kind of two questions. How can we benefit from the cloudness benefits? You need to have much storage of data. So regarding that, how can we benefit regarding the cloudness? And the second one is, I'm really excited to know what kind of professionals you use to, recording and managing this all data, and including the generating the QR code, and also for the managing the data quality and data use. Yes, and so have you ever faced like a kind of fake certificate, something like that? So if so, what kind of management or what would the experience regarding that? And maybe in some regions we might use the aggregate data in some scenarios. Maybe that kind of is some might be done. So do you use any kind of aggregated data reporting mechanism rather than the individual data? Recording the every individual data is very difficult at some scenarios. So in that regard, we might use capturing the aggregate data. So if there is any experience regarding this. And the last one is, do you have any published documents regarding your best experience or the challenge or the journeys that you have came up with till for this great achievement? If so, it's really helpful for us to learn on that, and for the digital solution in general. Thank you very much.
Thank you for your questions. And that reminds me, I think I'd missed one of the questions from the table at the back, where you had asked, how can mistakes be corrected on the certificate? And I think that's a similar question here as well. So there are two ways that we have ensured, quality of data. One is to first only absorb or ask for an input of minimal data. That is one best practice to ensure that you are not taking incorrect data that is coming in. Second way to ensure that the quality of data remains as it is not allowing anyone to double write on it. Today, if I log into my vaccination, into CoWIN to see my vaccination certificate, I cannot overwrite any of this data. However, we did notice that, as vaccination certificate was becoming critical to opening up socioeconomic activities, there were a lot of individuals who maybe had an incorrect spelling of their name, or who maybe, had the date of their vaccination recorded incorrectly. So in these cases, we also provided for provisions of correction of the certificates on CoWIN itself, wherein if 60% of their name was remaining as it is, they were able to, the system would take the change in the name along with verifying that it is the same name as recorded in the vaccine in the identity document that has been provided. Secondly, what was also observed at times was that individuals might have used different mobile numbers to get both the doses. Now, if you're using different mobile numbers, the system would identify you as two different individuals, unless you have given the same ID. If you're using the same ID against a second mobile number, the system will not take you. But there is still, this issue that is observed that, because an individual might be in a hurry, so they might produce a second ID. Therefore, they would now have two first doses certificates across two different numbers with two different IDs. So we also provided for a facility on the CoWIN portal for individuals to map both of these first dose certificates under one user and do away with that, two first doses, and instead have one fully vaccinated certificate. In terms of cloud storage, again, because of minimal data input, there is not a lot of storage that is required per individual. We are using the DIVOC verifiable credentialing service, which is again a natively built service in India that is allowing us to create these QR codes in real time, which are digitally verifiable and are encrypted. So that is ensuring that there are no fake certificates that come up. So you mentioned that, someone can try to, because there's a PDF file that is created for a vaccination certificate, someone can simply go into a PDF file and change their name or put in someone else's name and change the date or age. But what happens is, because there is a QR code at the bottom of the certificate, when you scan that QR code using the verifiable verification service on CoWIN, it will throw back all of the original details of the certificate. So that is one way for you to verify that the certificate which is being produced is actually of the individual who is showing it. So say, Amit has a certificate and I impersonate, I forge that certificate to change the name to Aviral on that certificate. I change the age, I change the location where the vaccination was delivered. Now, what will happen is, say when I'm entering Dubai and they are going to scan that certificate using the verifier. And when they scan that certificate, the QR, because it was issued for Amit with all of his details recorded there, it will throw back that the name of the individual vaccinated is Amit and not Aviral. This is the details of the vaccination, this is his age and gender or the identity document number. So that has been one of the biggest ways for us to ensure authenticity of vaccination certificates, and that has also enabled us to drive more fruitful conversations and faster mutual recognition of our vaccination certificates across the globe. In fact, the DIVOC service, which we are we have been using, is also being implemented in Sri Lanka, Cambodia, Indonesia, Philippines. So you could say that nearly 20% of the world's population is using that same certificate module of CoWIN. So there is that strong degree of verifiability. So, you may have your vaccination certificate platform already running. You could even just take this certification module of CoWIN for integration with your vaccination platform, and that would not cost you incrementally too much, but that would allow you to bring in verifiable credentials for health within your country, and also enable smoother travel for the citizens. I hope that answers your question. Oh, you had also asked about aggregated data. As I had shown on the dashboard, we are only showing anonymized aggregated data to any stakeholder. you cannot, unless and until you are a vaccinator, any other individual cannot just retrieve an individual's data. So that's just how we have designed the system to also ensure the privacy of data for all of the individuals, and so that it never leaves the central repository, and there is no duplicate or mirror image of this data that has been created, uh, providing any possible risks for a data leak of this thing of our citizens. Do we have any further questions? Thank you.
Thank you so much, Mr. Avirol, for making such a wonderful presentation and also the effort to answer all the questions that were raised. Now, I think we would like to open the stage further and probably open the experience sharing further to all the delegates who are present. I would request all the countries, or any country that would like to share with us, their experience of how they've been implementing the systems, rolling out the vaccination programs. I would request that you make probably a short, brief presentation, and so that we also get to learn from what you've been doing, so that we could also take forward the experience from you. Dr. Jong, would you like to probably start? Thank you. It's my honor to invite the Director General at the Ministry of Health, South Sudan, to probably make a few comments. Thank you.
HMD, I don't. It's not. It doesn't have. It's okay. Sorry. It's okay. I assume it is still morning, eh? And I would like to say good morning. Well, thank you, Patrick, and all the colleagues that are here. I don't have a real presentation to share, but I have one slide that I had wanted to show, but probably will still guide my comment. I want to say South Sudan, as we all know, is still the newest country in the world, and we made a commitment to join the world and be among the member states, and the leadership made it clear that we need not to reach a platform as provided by GDC and the RIS program fits very well into the interests of South Sudan. And with this, I want to say, as far as COVID response is concerned, we know COVID has disorganized the whole world. Both those countries that have existed for centuries with the systems, as well as the newly emerging countries. And as a result, it has forced us to first be mindful of our common interests and our common fate in this world. And the fact that you are not safe and I'm not safe until we are all safe. In regards to this, and in regards to the COVID response in South Sudan, we know we only had our first case in April after many countries in the region had their cases. It might be simply because we were unable to detect the presence of the epidemic early on, like others. South Sudan is being labeled as a country with a fragile health system, a very weak health system. So taking time to detect is totally understandable. We are still struggling to build the capacities that are required for the implementation of the international health regulations. And as a result, our response to COVID-19 pandemic is very much based on the capacities that exist in the country. To come to the subject matter, we are only using District Health Information System as the national HMIS reporting platform for the country. However, given the challenges faced by the system in the country, much of the health care delivery is supported through donor interventions or partner interventions. And as a result, the biggest challenge we have is multiple reporting channels. I like what was presented earlier about systems that operate in silos. It's very much happening in South Sudan. And as a government and the Republic and the Minister of Health, we have made it a point that we must develop a system, a health information system, through the DHIS, which many other countries are using, with competencies that will meet the needs of all the stakeholders. That is what will actually stop the parallel reporting. In regards to COVID-19, and with support from our partners, and in particular the WHO, we have been using a system that is also interoperable with the DHIS system, but again, it remains a bit of a separate server for it, and that is managed by the WHO itself. So it falls within the challenge of having a silos approach, and that is simply referred to as ODK. Many of you might be aware of it. We have, for the purpose of the COVID-19 vaccination, pushed for integration and to have a digitalized COVID vaccination certificate, which many of us are now carrying. For us to come for this meeting, we had to have the proof of the vaccination, and we were able to get the certificate issued from the digital platform. And as a result, we cannot yet claim having a system that is competent enough or that is meeting our expectations. We count very much on this opportunity and other opportunities to learn from all of you who have come here, and also to get further opportunities of how we can be supported to strengthen, our reporting system and to digitalize the health system in the country. The government is using an information system with a government project called e-governance, whereby we need to digitalize. A number of other stakeholders and ministries in the country are already digitalizing for people to access the information, for people to enroll and register, and a number of platforms are being used for that matter. For the health sector, we talk of the health, the district information system, which is the DHIS2, and this is where we are doing or moving with a lot of investment coming from our partners. With regards to COVID, as I also indicated earlier, and vaccination in particular, we are not celebrating, but of recent, we have not been recording many cases as we used to have. Our testing, although is optimal, is simple, but the positivity rate has declined so much. We also know that the case fatality rate for the whole Africa, and in particular South Sudan, among other countries, has also been quite low. For some reasons that we really only thank God for, given the capacity that we have in the region and in the country. We currently have received still less than a million doses of the vaccines. To be specific, is slightly around 930 doses, and out of that, we have only used around 54% of those vaccines, and definitely we still have over 400 doses that are to be used. And I was happy to hear that in India they could also achieve this high coverage. However, I was very much interested to listen to the challenges, as I mentioned earlier. There has been a lot of vaccine hesitancy in our country, and especially among the young people, and especially among the females. There are a lot of misconceptions, and the social media, campaign against the vaccines, and issues to do with perceptions around, the fertility and all those things. We have used different types of vaccines in our country. We started with AstraZeneca of two doses, of course, and that was also perceived as one of the challenges, and the vaccination was moving very, very slowly, and especially among the women. We only improved we saw the improvement when we started J&J, and we could see, a very clear preference among the populations, and in particular among the females, and we have now seen, a rapid turnover, and as I said, we are currently having a slightly less than 7% of the population that is vaccinated. We actually have 6.78% of the people fully vaccinated, and of course, if we also look at those that are fully vaccinated, they are still only above 3%. So, if you also look at at the persons with the comorbidities, and we all know they are actually a high priority. We have vaccinated around 5.5%, and the elderly are the biggest, which is actually 7.4%. But I need to emphasize here, South Sudan, like Uganda as well, is a country where majority are young people. We have around 80% of the population is below 35 years of age. So you can imagine the percentage of the elderly people. Our people don't live long, so unfortunately. We hope that will improve soon. The only thing we could be proud of is, and we are the best in the region, if not the continent, is the coverage among the health workers. We have achieved over 84% of our health workers fully vaccinated. One reason for that is also the limited number of the health workers. You know, the whole country has no money. One of our biggest challenge is lack of adequate number and capacity of the health workers. So the number that we have is very limited, and good enough. 84% have actually received the vaccines. We are also happy that among the females, we have seen that those vaccinated, 45.2% are females. You know, we are happy to see this because it has been a bigger challenge for us. As we move on to talk about the cooperation and what we can do, we will be very much interested as South Sudan to partner with the GDC. We are very much interested to look into how best we can learn from the experiences of India and all the other countries. When we had the opening remarks earlier from Mr. Chari, he mentioned something good about South Sudan, the potential that we have. These are some of the things that at times, when we come together as humans, we try to encourage each other, and we see what we can do together. South Sudan is just like many other countries, has come up and is very much depending on what comes from others. And this life on handouts that are being provided as Africans is one of the most humiliating things that we still don't speak about it. I usually say it in many forums when we depend on the donors. It's one thing that governments and countries that have had experiences and have gone through what we are going through have learned and have come out of it and are willing to help others. But as much as they do that, we also need to have the commitment and interest to get out from what we are. At times when we keep getting support from the donors and international partners, we tend to be comfortable with that and look at it as it is going to continue forever. I work at the Ministry of Health as the Director General for the International Health and Coordination, and my daily work is interaction with the partners. My feedback to my people is always, I wish a time comes when we get out of this, when we graduate from this, because I came to realize that we as human beings, as many people are willing to offer, we tend to like that and move along with it. I could be a program manager, I could be a director general or a director or whatever, but in this process of appealing and getting things done, and resources are getting scarce all over the world, we know what COVID has done. So restrictions and limitations have become very many. We know the crisis around the world. We do not know what would be the outcome of the current conflict in Ukraine and the impact of that on the partnerships and what is happening. It is time for us to look at mechanisms that will allow us to have sustainable interventions and graduate from this dependency. One of the most difficult things we came to learn in this process is the potential that we have is getting out of our hands simply because we are spoiled by getting handouts all the time. One of the most difficult, and I think the whole room will agree with us, the most difficult job to do is begging. You know, is begging. That's the most difficult job to do. It's good to depend on ourselves, and please give us the opportunity to learn. Give us the opportunity to do things for ourselves. Otherwise, I want to say thank you for this opportunity. I don't have much to say. I have some of my colleagues here. If there is anything in particular to the system, Mila, that you would want to contribute, you are very much welcome. But at this stage, I want to say this is where we are. We are still a learning nation. We sometimes say we are a young nation, but you know, we are in a country that is younger than us. We are all, I myself and the team that is here, we are older than South Sudan as a country. But that, of course, does not prevent us to admit that there are a lot of things that we need to learn. But we must take responsibility and stand among the nations as a country and be responsible enough. Thank you. Moses, do you have anything to? Okay, thanks. If anybody would want to ask anything, any clarification on our side, we are ready to respond anyway. Thank you.
Thank you so much, Dr. Chong, for such an elaborate speech. As a GDC, at the core of our mandate really is to work with countries to strengthen their own hands to work for themselves. So our technical capacity programs, exchange programs are aimed at really enabling countries to work for themselves and build their countries on their own. Maybe I would now like to request maybe the second country. I don't know whether Dr. Meseret would come in next. Thank you, please. Dr. Meseret is a director at the Ministry of Health, Ethiopia.
Can I say good afternoon or good morning? Thank you very much for the great chance. Colleagues from the distinguished states and the government of India and its people, I would like to repeat my congratulations for reaching vaccinating like 1 billion of its citizens, and also it's an honor to be with you in this very important platform. And I would like to also congratulate my brother. He did the first presentation from Sudan. That's also South Sudan. That's also a big congratulation, because we see as African, when we have such success, so this will be collectively as a continent, we will definitely do best for our peoples. So I would like to take you through with, I don't have a formal presentation, so we have a different thematic area to coordinate the COVID vaccination rollout. The first and the very most principle is we have a very amazing coordination and governance platform, which is led by the minister, because without coordination and governance, nothing will happen. So this governance is not only at the central level, but we have this the same governance down there based on the context we have. You know, Ethiopia has at least 3 contexts. We have the urban people and the rural people, which we have agrarian and pastoralist community, even we have semi-pastoralist community. So based on that, at the sub-national level, there is also a coordination platform. That's also happening very well in the lowest district level, that we call it Warada. So we have this governance and coordination platform. So we use both in-person and virtual platform. You know, COVID really give us one of the health system strengthening capacity using, you know, before COVID, everyone has to get together in the same place. But now, because of the virtual platform, we can train people, we can do a meeting. And so using this virtual platform, most of the time we coordinate in this way. The second one is we are trying to maximize the capacity of the vaccine logistic delivery and the cold chain equipment delivery, you know, and the strengthening system, because COVID as an opportunity, we are trying our best to strengthen our health system. It's not only for the COVID vaccination rollout, but also for the routine vaccination. And because vaccination is a litmus paper for the health service, so starting from benchmarking of the routine immunization, this is also a golden opportunity to look into the whole service delivery can be well leveraged as well. So we are trying our best to capacitate the logistic delivery, supply, and the cold chain and equipment infrastructure is well, you know, than before that we had before COVID. And the third one is, you know, we are proactively trying to address the misinformation and disinformation of the COVID itself and the vaccination by itself. So we are trying a different, like a tailored way of approach, reaching out of our community to address this very critical point. It's not only happening in Africa, not only in Ethiopia, but also in the entire world, even in the first world population. Countries are suffering from, you know, they are really sharing the pain. How this misinformation and disinformation is really being propagated in the world, because everyone is closer because of the social media. So we are trying our best. Basically, we are really keen as an Ethiopian to learn more how we can really address the misinformation, particularly in the educated people, you know, because these are really very difficult, and the challenge that we face in rural areas. I mean in urban, in the towns, these are the challenges. Otherwise, this is not more a problem when you go to the pastoralist community and agrarian community. So I'm really keen to learn more from other countries as well. So for mitigation of this misinformation and disinformation, we are trying to use all the media outlets, the state TV, the state radio, and with a different language, we are trying to also messaging and reaching out of the community using a different media platform. And we also, you know, disaggregate, different methodologies to reach out the community, like using the religious leaders, influential peoples, trusted community messengers, and, you know, the leaders in the community who are really trusted, that we are using this golden opportunity. We are trying to message and reach out the community. And the other thing is, you know, we are trying to capacitate our health workforce, because without mobilizing and capacitating the health workforce, it's not really an easy-going task to roll out the vaccination, whatever the case. So we are trying to add a skill and experience for the health workers to vaccinate as much as we can, as many people as we want. So that's why today we crossed 20 millions of people has been vaccinated in my country, and it's really an honor. It is a long journey. It takes us for a year to reach out this way, and we really use a different service delivery modality to reach out 20 million. It's not a simple business even to reach out to 1 million. I'm really honored to say this, because we use a different way of approaching our people to get vaccinated, and we did 2 campaigns. One has been done during December 2021, and the second has been conducted almost in the completed phase. So that's why we crossed 20 million to get vaccinated. So for the service delivery, I think we use a different modality, like campaign, static, fixed. So there are different ways based on the community that we have. For example, in a mobile community, we use like an outreach, and in a static community, we use already existing health infrastructure and the health facilities are being used. Whatever the case, we are trying to mobilize as many people as we can, and we deploy many health workforce, and we also use our health extension workers to mobilize, like to provide information and to mobilize people to get vaccinated. We train this health workforce and we reach out our community in this way. The other modality of reaching out of our community is the school platform. So we are really keen and always trying to strengthen the multi-sectoral approach, because COVID is not only a health issue. It has an economic impact, it has a political impact, it has every impact, because the world has been checked by no pandemic except COVID in the last 100 years. So this is really a historical, terrible situation that the world is facing. To combat this pandemic, there is a need to collaborate with the different stakeholders, with the different actors, with the government sector. So that's why we are trying our best to collaborate and partner with other sectors. So we have a multi-sectoral collaborative platform. In fact, COVID is led by His Excellency, our Prime Minister, and our Deputy Prime Minister in the subnational, in the regions. The regional head of states are also the one leading, taking care of this agenda. So I can say COVID is a top agenda, a top political agenda in my country. So we coordinate in this way, and in the school platform we use this way to deliver the service. And the other thing is we work very closely with developmental and industrial parks. So we are trying to maximize our way to reach out our community in this way. So the targets are those age groups, 12 and above. So disregarding of any like conditions, everyone is a candidate for the vaccination. So the sixth component is adverse event following immunization and surveillance and evidence. So we have a great agency under the Ministry of Health. We have a very technical arm, that is the Ethiopian Public Health Institute, is mandated to work on the evidence, research, surveillance. So we are trying our best to strengthen our surveillance system. So we are doing that one, because without robust surveillance, there will not be any resilient immunization system. We cannot really reach to the immunization agenda 2030. So that's why we work very hard in our evidence part and innovation part, and also in strengthening the evidence and surveillance part. So for us to respond to and to mitigate for anything that happen and to proactively respond. I'm not saying only for COVID, but also for the entire vaccine preventable disease, we are doing our best in the surveillance part and evidence part. And AFI, we have also a designated agency and responsible for taking care of this, authorized for this. So the adverse event following immunization, this is also a good start for us, given the COVID pandemic as an opportunity. We are also institutionalizing this one to have to add up more and to leverage our system towards to the routine immunization system. The seventh is digitization. So digitization, I think for us, it has two components. One is the culture, information use culture, working on the soft component, and the second is the infrastructure. We have already an existing infrastructure. We have already launched in January 2018. We have the DHIS2. We have this system to bring a data from down at the household, even at the health facility level to the central level. So we have this infrastructure. So for the COVID vaccination, we are trying our best to capacitate and to not to have like a parallel structure. We are trying to leverage on our existing system. So now we train peoples in the lower district level, and we are trying to bring data through the DHIS2 system. And QR code, there is work on progress. I think my colleague Jacob and Johannes will say later on a few words on this, because there is a good startup. So for massive rollouts, there are issues that we'll definitely share with you, and colleagues will add at the end. And the other thing is, I think for the question that has been raised for the JDC. For the GDC, the Global Development Cooperation, I think we'll definitely further discuss. As an Ethiopian, we are always keen to learn and share experience. We may not promise here anything, but we are really very much interested to learn more and explore how best we can partnership with this very amazing innovation. And as a matter of fact, my country has a strong and a historical partnership with the government and peoples of India. We can definitely further strengthen our partnership in this regard. So we'll further technically discuss whether this will definitely fit with our system or not. At technical level, this is a startup. I can say this is a courtesy platform for all of us. So we will definitely discuss technically, and then we will understand more, and then finally, once we agreed, we'll table to the excellencies, and because the decision is up to them. So this is what I would like to say. Finally, COVID is not only a problem, but it's also an opportunity. So using this golden opportunity, I would like to second my brother's last statement from South Sudan. As an African and as an Ethiopian in the Horn of Africa, I think this is a golden time and a golden opportunity to look into leveraging our internal capacity to really start up the journey to start the graduation. Perhaps we have to be we might be out of gate. We have to be in the path to start, the exercise to leverage our internal capacity because we are really aiming to get graduate or to have a smooth transition from donor dependency. That's not a problem in my country, but still we have to expand our partnership and collaboration, because we are not at the time where we have to graduate. Rather, this is the time to discuss and to start our internal capacity to get more strengthened, and then looking forward to have a very smooth transition looking forward when we enter to the middle income country. That is a big assignment for us to take care of everything, to start the graduation process. Thank you very much once again for this golden opportunity, and anyone having any concern, any question, we are very much keen to share with you all the details about the COVID vaccination rollout or other experience if you need. Thank you very much once again. Thank you.
Yeah, thank you so much, Dr. Mesret, for such a quick and elaborate presentation. I think one of the key things that has always come up in these discussions has been the question of vaccine hesitancy. That has come up, I think Dr. Mesret raised it, and Dr. Chol as well raised it. And I think Rwanda has been very good in this. So maybe I would request Mr. Sivamona to briefly touch on that while speaking probably more broadly of the experience. And I also know that they have quite an interesting system. We would probably like you to maybe briefly touch on it and how we could move forward in collaboration. Thank you, Mr. Hassan.
Thank you. Good afternoon. Thank you a lot. So it's a great pleasure for me to be part of this conversation and also to have this opportunity to share on the experience in this exercise we are conducting, all of us together to fight this pandemic. Which was challenging to all of us. So I don't have so many slides. It is only 4 slides, but it will illustrate what we have been doing in Rwanda. So let me start with number of doses we received, because actually yesterday, on 3rd, actually it was anniversary of the first year, because actually first doses we received all of them on 3rd March 2021, and then the national campaign was launched on 5th March. So meaning that today actually we're celebrating 1 year. And as you can see, we have received so many doses, more than 22 million doses received so far. And if you look at our target, actually it is 70% as other countries, and 70% of the total population of Rwanda, actually it is almost 9.1 million. So meaning that if we provide 3 doses, actually we need 27 million. So it means that at least with available doses, we can assure that we can provide 2 doses and achieve 70%. On that graph, you can also see type of vaccines we have received. We have used more than now 6 type of vaccines, and I think Rwanda was one of the countries in Africa to use so many doses of Pfizer vaccine, because at the very beginning, on 3rd March 2021, so we have been able also to receive Pfizer vaccine, and also the second one was AstraZeneca. And today I have to thank again government of India, because on 5th March 2021, actually we received also the first donation of AstraZeneca vaccine Covishield from government of India, 50,000. And then with received doses, you can see what we achieved. Actually, the coverage today is very good. Now you can see fully vaccinated, we are at 60%, while for the first dose, we are almost at 70%, 68%. So meaning that this March, actually we are achieving the global target of 70%. And you can see we have also started to provide booster dose. We are at 13% today. And you can see on that graph actually where we came from in March up to date. And you can see in September we have been able to achieve the 10% as a global target. And then in December also we achieved the 40%, because actually in December we are at 43 fully vaccinated. So, and then saying on data collection and the real-time monitoring and also vaccination certificates, actually this is the flow we are using in Rwanda. So for us, actually to collect data and make sure that every person vaccinated has access to certificate, we are using DHS2. And that DHS2, there is so many variables, and there is 2 parts, one which can be used by healthcare providers, but also another part which can be used by the person vaccinated so that he can access the certificate. So you can see on this side, so this is the platform used by healthcare providers, and then after collecting all data, actually the person vaccinated can get certificate. And then to make sure that that certificate is not forged, there is also a QR code which can be scanned. And so when we scan, actually it will give you this link, and you can be it can be verified. So once you go to that link, actually you can directly enter our system. But of course, before going there, so I have to say that also we are publishing data on daily basis. So this is what we are giving to the general public, where we are giving number of people vaccinated, number of cases, cumulative number of cases we have had, people in critical conditions, and if also there is something who died from this COVID, actually everything is published on daily basis. So Patrick was saying, and the other colleague, the issue related to vaccine hesitancy. So actually for us to provide the full information to the general public, actually it helps a lot, because actually we are getting the trust from the public, because actually nothing is hidden to them. So we are always informing them, people vaccinated, people infected, death, people admitted in hospitals in critical conditions with symptoms. So everything is published on our website, and always we're using tweets to make sure that the population can access the information. So let me go to this link. I don't know if we have internet here, but if you go to this link, I think there is internet here. No, it can't project. So it can't project, but what I wanted to show you is that once we scan the certificate and we go to this link, actually we will have all this information, and it is very easy to know if the certificate really belongs to that person who process it, because actually there is ID number and also there is names. So this is something really very important, because there is no way of making sure that actually the person who possessed that certificate is his own certificate, because actually there is no picture there. All right. So once you go to that link, actually it shows you number of doses you have received, but also names and no, it's fine. There is ID number. This is my own certificate. So you can see there is names. There is also ID number. And for us, it is very easy, because actually even national ID numbers, actually we are accessing that database. It is linked with this immunization tracker you're using for COVID vaccination. So meaning that for us it is very easy, because everyone, even a child born, actually has the ID number. And also we have taken that advantage of also linking birth registration with vaccination. So meaning that today in vaccination, for routine vaccination, also we can know a number of children who are waiting for vaccination, so that can be easy also for forecasting. And if there is anyone who is missing also vaccination, because we can access that platform of birth registration. So actually it is easy to make sure that we can vaccinate all of them without lifting no one behind. So, and then for us, cooperation with GDC, so actually it is a good idea, but we are far away. If you see how many people we vaccinated so far, so maybe it may be difficult to make sure that we can introduce again this co-win system, because if you look at the number we have vaccinated, we are almost done. So we are at almost at 70%. But I know there is so many ways we can collaborate with GDC, because I have seen that already we are working a good job, not only in health, but also in the other sector. And the cooperation, Rwanda and India, actually it has a big history. So as I have said, on 5th March 2021, India was the first country to donate vaccine doses to Rwanda. And I remember a little bit before COVID, His Excellency Prime Minister of India was in Rwanda, where also he supported one of the villages to provide even cows. And that is a good sign to Rwanda. When someone gives you a cow, it means something else. So it's beyond cooperation. Actually, it is it is some kind of brotherhood. So for us, we are open for even other collaboration, and we think that also this is something which can be discussed once I go back with colleagues and see how we can benefit from this new system, because actually, it can help not only for vaccination but also for other system, because I have seen that also it is being used for, you are planning to use it for telemedicine. So this is something really very important. We think that it can help also the population of Rwanda. So with these few slides, actually, that was the experience from Rwanda. Thank you. If there is any clarification, I will be happy to discuss on that. Okay, thank you.
Thank you so much, Mr. Hassan, for such a great presentation. As GDC, again, we would be looking forward to engaging further with you. May I now request Mr. down South Africa, may I request Mr. Ngule to come and probably deliver some initial comments. Mr. David, please, you may take, if you would like to say something. Oh, yes, from Zambia. My apologies. I just missed these countries. Yes, please.
Thank you. And good afternoon to all of you. I am Ngola from the Ministry of Health. I'm Principal Information Use and Quality Officer at the Ministry. And I have my colleague who manages the ITC space back with me. So just quickly to share our experiences around the COVID vaccination process. We started somewhere around April of 2020. So we're just slightly below a year in terms of vaccination. And obviously we suffered from vaccine hesitance and would like to sit with Ethiopia to know how you leaped to 20 million
or of course Rwanda, that is almost hitting their target. We, on the other hand, have only been able to vaccinate 17% of our eligible population fully, but we've reached out to 27% with the first dose. So we have targeted children 12 to 17 years, and also the adult population 18 years and above. And that constitutes about 10.9 million, which is 60% of our total population. So as of yesterday, we have reached 2.9 million people with vaccinations. Of those 1.9, we've been able to fully vaccinate. We have some architecture in terms of how we built our COVID system. I hope it is clear. So we have the Africa CDC trusted platform that we are posting much of our data to from the vaccination center, where we have the provider seated interacting on DHIS2 platforms. So here a client walks in for self-registration, rather for assisted registration with a service provider, and we capture their details. Not so many, it's basically just demographic details, but we have also a few background details in terms of comorbidities, in terms of occupation, that we add to our vaccination registration. We have a paper version of it, which is just an A4 size registration form, and we deploy it mainly where we have challenges in terms of connectivity. So people can also go on paper and do it, submit that paper back to the district for upload into the DHIS2. Once our data is in DHIS2, we pull it up to an immunization registry and online web system which processes the certification. And for this one, you can pull your certificate on your own. So you get a one-time password, and then you view your record, and you proceed to pull your registration. So this is basically the architecture of getting your certificate. Either you do it yourself or you get assistance from a health personnel. So you log into the internet using your national ID, you find your record, you verify that it is correct, and you proceed to print it. If you find errors, for instance, on your record, you have to go to the center to have that corrected, and then you need assistance basically from the healthcare provider. Just quickly to show you a little video in terms of how to go about the certification.
Nation certificate online. It comes with a QR code, making it easy to be verified. Simply go to ir.moh.gov.zm to open the immunization registry on your web browser. Click on Get Vaccination Certificate, then click on ID field to check available ID types. Select the ID type that was submitted during vaccination registration, then click Continue. Fill in your personal details as they were submitted during vaccination registration, then click Verify. If matching details are not found in the system, a verification failed message will be displayed. If matching details are found, click Continue. Click on Verification Method to check available methods, then select the method in line with what was submitted during the vaccination registration. Enter the method details and click Send to get a one-time PIN, OTP. Enter the OTP and click Finish. And just like that, you will get your electronic copy of your COVID-19 vaccination certificate to use as and when needed. It's that easy. This message is brought to you by the Ministry of Health.
So basically that's the simple process to access our vaccination certificate online and by the individual themselves. But we have seen quite a lot from the CoWIN system. We are deficient in terms of self-registration on our systems. Our stock management modules are not so efficient or to the desire that would like them to be. You went on to mention what it could do in terms of integrating into national registries, and that's something that we could also like to explore in terms of client registry integration. So there are areas where we could cooperate or where we could actually sit and seek more technical advice in terms of how CoWIN could assist in what we already have or enhance what we are already doing. So thank you very much. Visit us. We have a ceremony coming up, the Kuomboka. We paddle across the river to higher land. It's a very nice place. Mining and tourism is some of our mainstay. Come to Zambia and enjoy our culture. Thank you very much. I will take questions if there are any. And my colleague Liswaniso is also on hand to respond to any of those. Thank you.
Thank you so much. May I request Mr. Lukwago, would you probably come? And maybe before you come, we have also a representative from Uganda who has also been with us here since yesterday. So maybe I would just give him some initial 2 minutes, and then he will come in and tell us what our Ministry of Health at home is doing and how probably we could work together in moving forward. My brother, Mr. Kecho, please. You may just greet us and probably some few comments.
Yes, good afternoon, ladies and gentlemen.
Good afternoon, sir.
I was getting worried that we are not in the room. So, thank you very much, members. I am called Okecho Lawrence Michael. I am the Director of Trade Information at Uganda Export Promotion Board, and for this month, I am the Director of the Uganda Pavilion. It's a pleasure being here, and based on what is transpiring, I am very excited, just like all of us, for us to proceed and get to where we want to get, to achieve our visions, our aspirations. This is something very, very important. And what I am seeing from the CoWIN and all these other presentations, I think CoWIN and the others are systems and processes that actually we need to integrate into other areas, because there's a lot of winning that come out of it. You can do a lot of things. You can do a lot of things with the processes that are in CoWIN. When the scientists were talking here, my mind was running into other things. I was running into how export information is run, production processes, and the rest. So I'm very excited, and I wish all of us the best. Thank you very much.
Thank you. Good afternoon, colleagues. Good afternoon. Yeah, I was also getting worried. So allow me to just give an update. I don't want to duplicate what my colleagues have said, but as far as I think technology, ourselves and South Sudan, as well as Rwanda, as well as Rwanda, I think, are adopting the same technologies. We're using the EpiVac in DHIS2 and probably the same processes to register and also to process the certificates. So I'll not dive much into that, but I think I'll just give an update on how far the Ministry of Health and the government of Uganda has gone as far as vaccination, COVID vaccination of all its citizens. Of course, it hasn't been easy. Like most of my colleagues have said, first and foremost, the vaccines, we got them through the donations because we didn't have capacity as Africa. But also, when it came to most of COVID hit us when Africa's countries in Africa, capacity-wise, were not ready, equipped, and also because our sectors are struggling a bit when it comes to human resources, like the Director General of Sudan hinted. So putting things together and really addressing this global pandemic wasn't easy on our side. So our target was really not too high because our vulnerable populations, like again the Director General said, we have so many youths. The percentage of Ugandans that are above 35 is relatively below 30%. So our target was about 17 million people that we targeted to populate. So as far as the statistics are concerned, we broke these categories into four. Primarily, when we got the first doses, we thought would start with health workers, and we had a target of about 150 health workers that we wanted to vaccinate, so that we safeguard them from getting COVID themselves in the line of duty. So we succeeded in that endeavor. At least we overshot even by 120% because of numbers. So currently, as we stand, those that are fully vaccinated, at least in that category of health workers, are about 75%, whereas we are sure all of them received the first dose. So again, it goes back to the issue of vaccine hesitancy and the myth and misconceptions that haven't been addressed really well. We had teachers because we thought that since schools have been closed for so long and we needed to open up, I think Uganda has been the last country to open up schools, if I'm not mistaken, because we opened up our schools this January, that is two months ago. We needed teachers to get vaccinated so that our kids don't get a brain jam. Most of them, when they went back to school, they couldn't even pronounce their names. So it was a challenge for us. Our target was about 700,000 teachers, and about 68% are fully vaccinated, whereas 98% got the first dose. The security forces, we envisaged to have 4 million personnel in our security forces vaccinated, and we are happy to report that at least 90% of them, security is security and the order is order. So 90% fully vaccinated, and we shot as well, because we imagined 4 million, but we vaccinated about 4.4. Now the elderly, that category, we estimated about 400,000, about 30% are fully vaccinated. You know, we have regions that don't believe in vaccination. That is mainly in the eastern, northern parts of our country. Karamoja, these guys don't want to know or hear anything to do with vaccination. Of course, we are still struggling as a country when it comes to the hesitancy bit, and also solving this big challenge of convincing people that vaccines work and they can survive 5 years after being vaccinated. And of course, there is this myth, especially among men, that vaccines have a way of reducing their manhood. It is a really big challenge in Africa, and we fail to convince the biggest portion of our population that really science has not yet found a correlation between reduced manhood and vaccination. So we need to do a lot of things there. The other thing is when it came to technology, but I think this is where colleagues from Rwanda, I think, have succeeded, and I think after here, I'll go to him and probably ask how they have overcome. Still, Uganda being a low developed country, we still face network challenges, but also a lot of power blackout. And when this came, we thought, but also it could be attributed partly to the fact that when we get these doses, most of the time they are about to expire, and we need to push them to our communities so that we realize absorption in a very short time. So we found ourselves having a lot of backlog in terms of paper, because even when it came to systems, we couldn't realize enough personnel to handle the gadgets, to enter the data. So we have a lot of backlog, and probably this would also talk to the fact that our performance is slightly low, what we report, because a lot of it is still lying in paper, not being entered. And this also has created situations where colleagues that have completed their dosage at times struggle getting vaccination certificates, because the data is not readily available in the data set, in the database, and verification is really hard. So those are some of the challenges that we've faced as a country. Coverage-wise, I think we've consumed our vaccines. We've used rudimentary methods of pushing vaccines, and also making sure that all Ugandans that need it receive it. But when it comes to using the technology, I think we need help, and there's I think a lot that we can learn from our colleagues who are here, but also our colleagues that developed the CoWIN. So definitely there are opportunities of a collaboration, I see, and of course opportunities of improvement, and we surely will reach out to make sure that at least even if COVID is in its last stages of going away, but there are opportunities that we can use the system for. So thank you so much for listening. And of course, if there are any questions, I am available to respond.
Thank you, Mr. Lukwago. I would now just for 1 minute request our last representative from Mozambique, but she speaks Portuguese, so if anyone understands Portuguese here, we'll give her time to talk. But otherwise, I will just request her to come and greet us, and then we would move on to the next session, please.
Good afternoon, everyone. My name is Salma Xavier. I'm from Mozambique. I don't have a presentation, but I would like to share vaccination process in Mozambique. We almost 11 million people vaccinated, full vaccinated until now, and we are using 3 types of vaccine, AstraZeneca, Johnson & Johnson, and Sinopharm. The process is difficult. We don't have electronic device in all units health. We're still using manual registration. When the people had vaccine, they have a small card like this, and if he want to have a certificate, he must take this card to have a certificate. We don't have an online platform like this in real time, but we do have a DHI base. So that's why we're using the platform. Thank you.
Thank you so much. I think this comes to the end of this session. I would like to thank everyone for sharing the experiences, all the countries. I think there is immense opportunity for learning, not just for learning both amongst ourselves, based on the experiences we've gone through, learning from India, learning amongst ourselves, Rwanda's experience on mitigating vaccine hesitancy, etc. It's something that GDC would probably like to engage further on to take forward to other countries.